and welcome. I'm your host, Ramesh Kumar, and I'm on a mission to bring value to the healthcare industry through improved transparency. And my goal from this podcast is to give you one aha moment that you can implement in your business, whether you're a TPA, broker, or an employer. In my day job, I run a company called Zaki Point Health that helps self-insured employers and their employees provide transparency, direction, and value by delivering a digital front door for the member that proactively steers them. Please like or share this podcast on your favorite podcasting tool so we can bring together a community of like-minded professionals. This program is brought to you by the Healthcare Administrators Association, HCAA. For over 40 years, HCAA has supported third-party administrators and the self-insured employer industry through educational opportunities from leading industry experts. For information on joining HCAA, please visit our website at hcaa.org. Our new sponsor for the 2024 season is Valence Health. Valence Health is the platform to simplify healthcare, the destination for employers, payers, providers, and members to reduce costs, improve quality, and elevate the healthcare experience. The Valence mindset and culture of innovation combines to create integrated solutions. Valence engages early and often to execute across the entire patient journey, from care navigation and management to payment integrity, plan performance, and provider verification. With a 99% client retention rate, Valence Health elevates the expectations to a new level of efficiency, effectiveness, and transparency where smarter, better, faster healthcare is possible. For more information, visit valencehealth.com. Today's episode is the second part of the two-part podcast recording that was done live at HCAA Executive Forum in Las Vegas in February. Unfiltered, unmissable, and unleashed. I am super excited to have Fred Goldstein, co-founder and lead host of Population Health Week, a weekly radio show, a podcast syndicated on Healthcare Now Radio, and the host of the ACMP podcast series. Continuing with the topics today, you're going to hear opportunities in 2024, digging into primary care and other specialist programs, PBM, transparency, rebates, weight loss, reinsurance, and a whole host of things tied to price transparency and the data. But we're also, in this second part, going to cover things like what mid-sized TPAs versus advanced TPAs could be doing in 2024 as opportunities. Let's dig in. So telemedicine, obviously, baked mental health, we talked a little bit about there. The two other areas that keep coming up, I think the pharmacy side, we've talked gene therapy and the other kind of medication, weight loss medication. Things more broadly in the pharmacy space, PBMs, policies around biologics, what's happening there and what to watch out for?
Yeah, we're also going to see more of these biologics come out. We've now seen biosimilars, and we now have the first generics. You all recognize TPAs and the PBMs, the games that are played with rebates and things. We now have companies that do straight pass-through and things like that. But it's been fascinating to watch the first generic come out for a biologic, and it's not named because the biologic has this name and the generic doesn't get the name, but it's the exact same product. But what you're seeing happen is the PBMs are not switching to the generic because they lose the rebate, and they keep selling the brand. And so,
is that the kind of stuff in Johnson & Johnson's case right now? Or is that?
Yeah, I don't remember which product exactly it was in this case. That also means a lot of times is depending on the plan that the employer has, that individual may have a higher copay and out-of-pocket. And so it's really important, I think, that we begin to look at these things a little differently and particularly try to maximize the individual's opportunity to be able to handle these costs and things. And I think we're going to see some more pressure on some of this, but it's really important. We've got some examples here at the conference of pass-through PBMs and things like that, and I think that's critical to look at, or Mark Cuban's PBM. I just had somebody I was talking to who's having difficulty with one of their friends paying for a product, and I said, have they checked either Mark Cuban's or GoodRx or one of those? They may be able to find it cheaper than they get it through their plan. And we've seen a couple of large payers drop their big PBM and go with Mark Cuban's new one.
So yeah, this is a very complicated area to navigate, right? There are 50-odd PBMs. Some TPAs are having to integrate all of them. Their brokers get commissions involved in this. How are you supposed to, whether you're a self-funded employer or a TPA, how are you supposed to navigate that? How are you supposed to cut this out and make a clean switch to Mark Cuban or whatever else?
I think we're asking a lot of people, and I heard this one earlier too, which was, hey, do you think we should hold the HR director accountable for our health plan and our costs and penalize them in essence if they don't save us money through the health plan? But do they really have the expertise to look at that and make those decisions? It's really pretty complicated. So I think it's important that we bring in some expertise and talk to people who really understand it. In my mind, there's a lot of hype in healthcare, a lot of people selling hype. This is going to cut your costs here, or do this, or do that. And a lot of times these solutions don't have any data behind them. Or they publish their own, or they paid a consulting firm to publish it. And so I think it's important that we recognize this is a complex area. Pharmaceuticals are very complex. And getting some expertise in, for example, one of the brokers I know who's got a pretty large national brokerage group that he runs, he's got 2 PhD pharmacists who work with him. And what they do, they literally ask on their bids, I want you to give me the individual price I will pay for every single line item product, pharmaceutical. And then they compare that up between the vendors, the various PBMs, and look at it that level of detail, and then say you're not going to do rebates or they're all coming through and that kind of stuff. And then obviously you've got to look at some of the other ways. Suddenly a company puts in some sort of a management program or something, or administrative program, and move the fees to that. It gets a little complicated.
So kind of use PBM consultants effectively and to work through the mess here. Price transparency was a big kind of year last year. What are you seeing there in 2024? Where do you see price transparency headed?
We're supposed to have price transparency, right? Hospital pricing. I don't know how many of you have seen it. I haven't seen a lot of it. I will say it was interesting in Florida. The state actually put out a data set on what had been paid for services, and you can look it up. And you can take, for example, a knee in Jacksonville, and it'll show you this between Baptist average price, Mayo's average price, St. Vincent's average price, and things like that. So we're getting there. But again, just having cost data without the quality data is dangerous.
Yeah.
So, yeah. But I just had what did I just have done? Some PT. And 2 sessions, the gross charges were $1,500 for 2 PT sessions. The insurance paid $200 and something, and I think I had an $80 payment, $40 for each session. So it was like $300 out of a $1,500 priced bill. Yeah.
So there is a lot of transparency, lack of transparency. So what I am seeing is, I'm kind of quite involved in the price transparency space, is the usage is really, really abysmal. People are not really logging into these tools, and this was expected. Even if you talk to any TPA a year ago, they'll be saying, well, I don't expect this to be used at all. But I kind of, on the flip side, whether it's 2024 or whether it's over the next 3 years, first of all, the data, the access to this data is so valuable for the industry, so valuable for creating these direct contracts, so valuable for even insurance companies or carriers or networks to, I can see that this hospital is contracting at this rate, and maybe I should also lower my contract rate. So it's going to have this impact, underlying impact in how things will be contracted. And so this data is quite valuable. The second part, I think you talked a bit about this, Fred, as well, is price on its own is not really meaningful for the member. And often when you're doing these care navigation programs, and I see Michelle in the audience here, yes, who talks a lot about quality as well. So how do you combine cost and quality is going to be key. And I think only now we are seeing the cost data is getting cleaner and cleaner. It took a good 12 months before these machine-readable files actually were making any sense, and they kept changing as well. So adding this layer of quality and cost is going to be critical this year, I think, in order to make it useful for care navigation. And then I think there's a whole element of member is not going to be driving down the road and getting a knee surgery and suddenly saying, let me look for a lower cost place. It's actually, if I turn left, it is actually 50% lower. No, nobody's going to do that.
it has to start from much earlier. It has to be where you engage the member, and you engage the member more around what they're looking for, what the care need might be, and this might be a conversation, a part of the conversation. So price transparency on its own is not going to be the thing people are going to be searching for, but that tool is useful to enable the customer support rep or the care navigator or the member and to use it more appropriately with quality data. But I still imagine whether some of the leading TPAs who will use it more effectively will actually gain from this by building new products on top. Whether it's 2 or 3 years down the line, it is going to have a major impact across the board.
No, I think you're right on target. And you mentioned something else that's really important that comes back to this, is this idea of getting people to understand earlier what might be coming. And years ago, I actually got the Medicare annual wellness visit into the Affordable Care Act, which was a way to try to present to the person, these are the issues and your risks. Here's what you need to get done in the next 5 years, and here's what you might face. So let's work to head that off. And that gets back to then primary care. And a good primary care physician is going to say, look, let's look at you holistically, understand where you're at, and create a plan for you. Maybe we can head off that knee on things like that.
Yeah, even and making that perhaps data available to the primary care provider.
Yes. Yeah.
That would be good for the industry overall. Which kind of leads to, I think we touched on this member experience, member engagement. We talk a lot about engagement, and I kind of think of it differently, which is rather than trying to use engagement and trying to engage members, it really should be more about helping the members connect with what they really need, connect with the care they need. And through that, you're going to be able to engage them better. But what are you seeing when it comes to member engagement?
Yeah, as I said earlier, that's the holy grail of population health, is getting members involved in their health, understanding where they're at today and what they can do to be better tomorrow. And I've looked at it a bunch of times, said to myself, how does Amazon get me to click that button to buy that item? How does eBay do that? How do the movies do that? Netflix, etc. And at some point, we're going to take that kind of technology appropriately and apply it to the individual. And it's really the ultimate precision medicine approach. Not only do we know from a precision medicine approach that based on their genome, they're going to respond to this depression drug, they need to take it at these points of time, but we're going to understand the person well enough to say, if I message them with ABC at 6:30 in the evening, that works. And they do it. And that's that whole thing. And I think we can play a pretty strong role of that with technology. We already know that if we email somebody, it could be 3 days, but if we text them, they're going to respond within 3 minutes. And so back when we did a high-risk maternity program for the state of Arkansas Medicaid, back in the early 2000s, the young mothers all said, don't call me, text me. And so those kinds of things I think are going to be profound. And we can do that with tech. But I think that's an area where perhaps AI can allow us to begin to segment individuals, not just low, moderate, and high risk, but even down to an N of 1, which is the ultimate goal, to know exactly what they need and what to do to help them engage.
Yeah, you talked about AI. I think fascinating topic. We'll be remiss to not touch on where in 2024 AI can have an impact. I would love to hear your thoughts. I have my own opinions on it. Where do you see it?
Let me start first with AY.
Okay.
Why do AI? I think a lot of people think, man, I can just take this thing and I can apply it anywhere. And really not. We originally had companies saying, wow, we're going to use it to diagnose X-rays, this and that, and it's getting good. It can do some of this stuff, but it hasn't been well accepted by mainstream, probably because it's maybe an income reducer or things like that. But it's really about augmenting and not artificial intelligence. It's augmenting the system, augmented intelligence in a sense, to take the doctor, et cetera. But I think where this can have huge impacts for the TPAs and anybody that's doing all these processes is in those processes. Whether it's remote robotic process stuff, where I know one company that they were doing claims reviews overseas, had hired a company, and every morning the staff would come in and pull the claims from last night and sort them out and put them all into stuff. And they wrote a robotic process operation system that during the night it hits all those EMRs, pulls all the data down, puts it in front of the person, and they walk in the morning and it's all there. It's in the right fields, it's all set up. Or UC San Francisco uses this. They get 300,000 faxes a month. They've got a ton of these referrals. Their system, their NLP system, can read that understand what the document is, what they're in the fields, which fields, and say, that's a referral. Oh, that's to this clinic. Okay, we're going to look at the schedule. We can set them up at this time with this doctor for that condition, and then before it's approved, it goes in front of a person. And it just cleans up that whole process. And so efficiencies around workflow are a huge opportunity. Now, where you get in trouble is what we're seeing with the claims processing stuff that you've probably seen the companies being sued for using AI to do claims prior authorizations and things like that. And so I think the article from ProPublica was on a buddy of mine, a colleague, Nick Vanterhayden, and his claim was denied and by Cigna. And when they looked into it, they found that in 2 months, they had done 300,000 denials through this AI system. The average time that the medical person spent reviewing the claim was 1.5 seconds. So
and these are like high-dollar claims? Or
these are just general claims. And I would tell TPAs this as a message. Prior authorization is like a big hammer, and you think everything's a nail. Use prior authorization only for those groups or those areas where maybe they're not quite doing it right. So an example of this with a friend of mine, they had a drug that was being prior authed 100% by a health plan in their allergy clinic. And at the end of a year, the clinic pulled the data and realized that every one of those prior authorizations that they'd have their staff work on, 20 minutes, an hour, whatever it took, were approved. So they called the plan and they said, do you realize you approved 100% of those prior auths you made us do last year? And the plan pulled it. No reason to prior auth that clinic. They're good. They're doing the right thing. So don't just generalize that every one of those, I got to hit every doctor with this. Find the ones that are outliers. A classic example of this also, the number one ACO in the country is Palm Beach County ACOs in Florida. Made the most profits every year. Every year when they first started, they took the bottom 10% of their providers and dropped them each year until they got a good network.
Yeah, it sounds like the technology is still a little bit early stage. There's all these kind of issues. It's not trained properly, these models. So you have to be careful. You need to have a human eye on top. And so are you saying maybe for prior authorization, certainly be careful, don't do it?
Or medical areas. And I think also you talked about something, another area, bias. We saw a huge bias in some of these. The data set that goes into it is missing certain populations of people or certain people, and so what comes out of it is wrong. It's biased. It treats people differently. And we've also seen issues where the data itself may be in there, but people are treated differently, and so it comes up with the wrong answer again. So it's really important when you're using AI tools that your data sets are really appropriate, relevant, and rich, and represent the population so that what comes out of it is good. I think there's great opportunities to use this in chat. I think you'd mentioned chat in our conversations, and you may want to touch on that, but I think there's a great opportunity there.
Yeah. You should think about the questions, but let me add my color to this AI, and the experience I've had is, so TPA's operations are very intensive, customer support intensive, and as you're trying to scale, very important to see how can AI help you support members. Now, you could think about conversational AI bots to directly support the members, but maybe you're not quite ready for that. Maybe your population is not ready for that. But can that actually help your CSR reps who are otherwise spending 7.5 minutes to 10 minutes and having to call back the next day and you can't get hold of the member? Can that CSR rep be equipped with a conversational bot that can help them quickly answer these questions? So there are so many different ways of bringing this data and these models in front of the CSR team, the care navigation team, or the member directly, or even providers. Providers are calling in a lot.
I'll add for efficiencies. One of the individuals I interviewed for my podcast was a CIO at one of the major hospital systems in the United States, and he said that he anticipated that they could do without 30% of their employees once they get it all going. And one of the examples he gave was, we take a chart of somebody and we're trying to analyze how much oxygen they use during the stay and what periods of time and this and that. And it took 4 hours for a staff member to go through and abstract the information from that chart. They wrote AI, large language model, to do that. That takes 30 seconds. And they don't need that employee anymore. And so those kinds of things, I think, are areas where you could yourself, within your own operations as a TPA, create efficiencies that can have profound impact on your pricing and your success.
Yeah, scaling operations. So we talked a little bit about the data there. I think all of these ideas, trends that we talked about, COEs to gene therapy to other targeted solutions, point solutions, telemedicine, telehealth, at the end of the day have to sit on a foundation of data, understanding your member population, the risks and behavior traits and things like that, and how do you use that data. I don't know what your kind of thoughts are. What can TPAs be doing in 2024?
I think better understanding your data is the initial first key to do this. What issues your members are experiencing. And one of the issues you also to think about is everybody focuses on the high-risk, high-cost patients. But just because they were high-risk, high-cost this year doesn't mean they're going to do the same thing next year. And if you don't move upstream, your low and moderate-risk people are going to be high-risk next year. And so you have to really create a broad program to take that data and understand who in this group may move, or what can I do for this lower-risk group to ensure they stay low risk. It gets back to the work that Dee Eddington did at University of Michigan around the natural flow model and looking at how this model flows when you do nothing. And over time, people get more risks and they cost more. And so if you can move upstream, and I'd also tell you this, as you look at your providers or your contracted individuals out there, make sure they're presenting real data to you and it's not hype. There's a lot of that. There's companies that say, well, you had 400 high-risk people last year, and this year, those high-risk people, there were only 300 of those people this year. That's right. There were 400 high-risk, and those people, 300 of them were left. But you had 150 move from the low and moderate risk into that high-risk category that they don't tell you about. So look at your stuff realistically and understand what the data means.
And it could be a differentiator. It could be a great way to engage the employer. It could be a great way to engage the broker, and a great way to pick the right solutions, the right point solutions, rather than just have 50 of them bombarding on you because the broker says, oh, we need it. You can say, well, our population only needs this or that, or whatever. So it can actually give you more clear direction and take you away from being stuck in customer management to claims processing to a bit more value-add space as well. So I think data is key. It's your asset. I think every business's asset. You have to treat it like an asset and use it wisely. Questions from the audience? Let me repeat that question for those who couldn't hear. So it's from Michelle from JP Farley. Quality data, which is critical. We've talked about it. How do we create the right weighting? What aspects of the providers, whether it's the outcomes, efficiency, whatever else goes into it, how should we be thinking about quality and the weighting models?
Yeah, I think there are groups out there like Leapfrog, it does hospital quality measures, and there are others, and they're all getting better, which is good, and we've got to get that information in the hands of the people who can use it. And one of the other things that we typically make mistakes with is we measure process a lot. It's great. Look at this. We took our people with diabetes and look at how many of them got an A1C test during the year. It's twice a year. You got your foot exam, your eye exam, and we hit those. But did their A1C values get any better? We need to measure outcomes, and you need outcomes from the provider groups. What was your readmission rate? How many people had a failure on a surgery? And those kinds of things versus, well, we had an average stay of 7 days, and they had an average stay of 5. But what happened? And that's where I think we're getting better. But really, and that is a difficult thing. Where do you get the outcomes data from claims? You got to get it from the HR. Mm-hmm. So you got to integrate your stuff, and we're getting there. We're not there, but you're beginning to see more and more of that, and that kind of integration. We pulled together clinical data back in the day. We had to pay the doctors. We paid their office to fill out a sheet and send it to us that had their lab values, that had their HIV viral loads and T-cell counts and things like that. And so we could say, yeah, not only did they get the test, but here's what the test results look like, and we could show that the number of people who had undetectable viral load was higher. And so outcomes data is ultimately the key to measuring quality. Mm-hmm. And also, it is important to understand the level of risk that provider was taking. Maybe they have higher risk patients, but they don't all have higher risk patients. And so that claim that, oh, mine are sicker than yours, there are ways to look at that and even out that data.
So one source is Dr. Marcy Macri, who has come and spoken here as well. for certainly the surgery side of things, they have done some work around quality ratings. Good source to look into. There may be other as well, but I think outcomes is really the North Star here. Any other questions before we wrap up? Just to repeat the question, it's basically when we talk about the prior authorization, particularly for some of the low-value items, can we use AI? Can we use clinical pathways, heuristics like that? What should be the approach? Can we scale this better than just prior authorization on the phone?
Yeah, I think you can. I absolutely think you can use AI to do many of these processes. And it gets back to something else I said. The underlying dilemma we have in healthcare is ethics. There's nothing wrong with fee-for-service until somebody decides to do more. There's nothing wrong with capitation until somebody decides to do less. And so it's really, we have to make a decision when we set up that AI model for claims processing. If it's ethically correct and we've done it for the right reason, it'll be good. But if it's there to just create and hit everybody and not identify that this provider is actually really good, so we actually can flip the switch right away when we know it's from Dr. Mary Smith and goes through, then I think we've created a better model. And that then looks at Mary Smith has better outcomes, or Mary Smith has chosen the right stuff to start. And then I would also say this, there are areas where we don't know what the right thing is to do. And in those areas, we have to provide the leeway for providers to do what they feel is in the best interest of that patient.
Sounds great. Well, I thought just to finish off now, I want to leave this for the audience, for our listeners. We thought about, let's take 3 categories of TPAs. You've got the getting things going, small TPA, does a great job of claims processing. That's segment 1. You've got the segment 2, a middle-sized, 20,000 employee lives TPA, has some solutions, established partners, has maybe ability to do various carve-outs of solutions. That's the category B. And you've got the category C, these advanced TPAs that have clinical programs in place and their own clinicians, category C. What are maybe 1 or 2 steps, if you had to think about those 3 archetypes, what are the 1 or 2 steps they should be thinking about when it comes to 2024?
Yeah, I think for the first group, I think you and I have hit on this pretty hard, is understand your data. Take a look at your data, understand what's going on in your system, so then you can begin to develop some solutions based on what you found as issues within your operations. As you get to the more advanced ones, then it becomes, should we be putting in centers of excellence? Can we look at various chronic care management models or things like that? And also, can we look at alternative payment models? Perhaps we're going to bundle our orthopedic hips. But understand this with bundles. Bundles are great for getting a singular price, but it does nothing for variation. If somebody wants to do more hips or more knees, you haven't cut it out because they can still do them. You've just set up a payment mechanism that's a singular one. And there again, looking at quality and the reasons for it. And I think when you look at that third group, then it becomes, what are the more innovative things that we could be looking at, such as AI, global capitation, really looking at these narrow networks and centers of excellence, and explaining to individuals why you've set that up and their doctor perhaps is not in the network or their hospital is not in the network, and showing that quality outcomes data, et cetera, and creating these tools that you've talked about potentially to engage or to get individuals more into their care.
Wonderful, wonderful. Well, so there you have it. Thank you, Fred, so much for sharing your thoughts, and it's been a great conversation. Hopefully some good takeaways, maybe an aha moment for our listeners.
And I would like to thank Valence Health, our sponsor of this show. Please join us again for another podcast in the series brought to you by HCAA's Voices of Self-Funding. Please like and share so we can build a community of like-minded people. And tell us about topics that we could bring to you next. Please watch your email for updates on upcoming guests. I'm your host, Ramesh Kumar of Zaki Point Health.